tendinopathy. So don't worry, the subtitles should flatten too if you can't have trouble with my understanding my accent. And I think the reason for this is that more and more, I suppose, in the athletic domain, 1 in every 2 athletes we know, and particularly in long distance running, will develop Achilles tendinopathy at some stage in their running life, for want of a better word. So these type of athletes will present to us in clinical practice. And the challenge for us as healthcare practitioners is how do we optimize the outcomes for these athletes? How do we get them back onto the track quicker and get them up to their previous levels of performance? And yes, and I categorically state that exercise is the gold standard, and load management is the gold standard, as we've heard from Jill throughout this weekend. But how can we supplement that? And I think the role of psychosocial factors is really, really important in terms of getting the athletes where we want to get them. And hopefully you'll agree with me by the end of the session. So I think it's fair to say, and I spoke about this previously in Aspetar, is that we all have our assumptions when it comes to tendinopathy. And as many can tell from my accent, my melodious Irish accent, not as good as Kieran O'Sullivan's melodious tones, but we all have our assumptions and inherent biases in life. And some of the assumptions that we have, for me as an Irishman, is that it always rains in Ireland, or that we all have ginger hair and we only eat potatoes. And although there may be a tenet of truth in some of what I say, that's not necessarily true. And I think that's also the case when it comes to Achilles tendinopathy and Achilles tendinopathy in athletes. And as I said, exercise interventions remain the gold standard for the conservative management of mid-portion Achilles tendinopathy in athletes. And we have the assumption that we prescribe the athlete the exercise and they return to play. And it's a very linear relationship. And it's very clear-cut and it's very easy. But I'm sure, as many of you as healthcare practitioners might agree, it's not that easy. And it's very, very complex. And it's very complicated, and it can be frustrating injury for the athlete, for you, the healthcare practitioner, and also for the coach involved as well. So by challenging some of these assumptions and biases that we have about Achilles tendinopathy, and in particular psychosocial factors and how to optimize them, we can hopefully improve the outcomes a small bit as well. And as I said, we know that exercise helps categorically when it comes to Achilles tendinopathy. So what you have down along the bottom is your interventional study over the last 15 to 20 years, and up along the side you have your pain scores. So up the top, 100 is maximum pain, 0 no pain at all. And what we want to do is pre-intervention is red line, green intervention is green line is post-intervention. And what we can see is consistently across the board, we can see that the pain drops in varying amounts, but pain improves. So exercise helps people with Achilles tendinopathy. And again, these are studies from athletic and non-athletic populations, mainly in terms of Alfredson's heel drop program, but in the last recent years moving on towards heavy slow resistance training, as Jill talked about, storage release type rehabilitation plyometric exercises. And it's the same when it comes to disability. So exercise improves disability as well, and disability as measured through a VISA-A score, which many of you are aware of. So again, 0 to 100, the lower the score, the worse, the higher the score, the better. So red line is pre, green line is post, and we can see that exercise improves pain and disability in Achilles tendinopathy. Okay? Fantastic. Simple. Game over. But unfortunately, it's not that simple. And there's the comforting lies and pleasant truths when it comes to Achilles tendinopathy, and we can pat ourselves on the back and pretend that we're fantastic at treating Achilles tendinopathy, but that's not necessarily the case. We know that up to 60% of athletes will have continued symptoms in Achilles tendinopathy. We know that 50% of those will actually rate their satisfaction as moderate to poor. And we know that 40% will have contralateral symptoms, as many as 40%. And what's actually striking for me is this one down here in terms of recurrence rate, and particularly in track and field athletes. In athletics, that can be quite worrying. There's a recurrence rate of 27%. And the reason I have a star beside that is because this is data from football, so from UEFA Champions League data. So this actually isn't based on athletic populations, long distance track and field athletes. So that number may actually be higher in terms of recurrence rates and following up these patients. So again, we may pat ourselves on the back and say that exercise works for Achilles tendinopathy. It's good, but we can do a whole lot better. So we can double down, we can fold our arms and say, look, no, it's the patient that's wrong, it's the coach that's wrong, he's not implementing my load management program, the patient's not doing these exercises right, it's their fault. We can indeed do that, we can double down on it. Or we can think about it a bit differently. and try to go to the nub of the value and look at it from a different perspective. And I think that is the whole point of today's presentation, is can we look at it a bit differently? And I think Jill covered it very nicely, and Peter as well, in terms of, yes, differential diagnosis is really important in terms of medication-induced fluoroquinolones, diabetes, peroneal tendinopathy. But normally that's not the type of population that we would see in athletics. We see the classical mid-portion Achilles tendinopathy. So how can we optimize those outcomes for the people in Achilles tendinopathy in athletic populations? Do we double down, or can we adjust some things? So can we adjust some things by recognizing the role of psychosocial factors? So in terms of exercise selection for Achilles tendinopathy, this is something that I must give reference to, as Ben Cormack, his guy on Twitter, well worth a follow in terms of exercise interventions, promoting alliance and rehabilitation. So this is a graph that he often quotes on Twitter, and I quite like it because I think it covers many of the aspects of exercise very, very well. And I think we're particularly comfortable with these two areas. So when it comes to load management and exercise prescription in Achilles tendinopathy, we're quite good at this. So as Jill spoke about yesterday, about how we can identify dysfunction or maladaptive movement patterns in people with Achilles tendinopathy in terms of hopping and jumping and spring storage release. We also know in terms of the Alfredson's heel drop program, or heavy slow resistance training, or progressive overload, or Karen Silbernagel's work in terms of continued running. We know that there's exercise interventions that we can play around with and how we can manipulate those variables. But I'm not quite sure we're very good at this side of the scale. And I think we need to recognize this in order to optimize our outcomes for our athletes as well. And I would probably, in terms of athletics, I would probably add on another small bit to that as well. And I'm sure many of you might agree, working in the athletic environment, in terms of the social environment in which the athlete exists as well. In terms of social pressures, in terms of competition pressures, in terms of relationships with the other athletes, in terms of relationships with the management team or financial pressures. They all have an impact on the exercise selection and ultimately the outcome of your exercise as well. And I think it's really, really important that we try and identify these factors and promote them and encourage them as well. So this tenet here will be our mainstay, but potentially we need to look and try and optimize these factors as well in order to get the whole lot of the picture, the bigger picture as well. And there's ways we're going to try and do that, and I'll speak specifically about Achilles tendinopathy patients that we would have followed before. So when it comes to psychosocial factors, the data that we have done so far, it's broadly speaking, we have found that these are really the main areas that we like to focus on when it comes to psychosocial factors in Achilles tendinopathy. So some of these you might be aware of, or I suppose can familiarize with, in terms of fear avoidance beliefs. So athletes may have fear avoidant beliefs about imaging, and we spoke about that, about the poor correlation with imaging when it comes to tendinopathy and Achilles tendinopathy. And sometimes our patient or our athletes becomes fixated on imaging changes or returning to play once their imaging changes have settled down. And we heard on the previous session in terms of stress fractures as well, and bone stress injuries, about that not being a direct correlation or decision making in return to play. But unfortunately, athletes can become a bit fixated on this aspect up here. And there's other factors as well that I'm going to give you some patient quotes or data that we collected that manifest in some of the things that we're going to talk about here in terms of treatment expectation or coping strategies. So does the athlete really understand the loading program that they've been prescribed, what they're going through? Do they understand training load and appropriate training load? Can they progress their own exercises? Can the coach progress the exercise? Does the coach understand the training load that you prescribe to for the athlete with Achilles tendinopathy? They're all questions that we need to ask ourselves. And these are some of the factors that may be relevant in Achilles tendinopathy as well. And I think it's really important too to recognize that, because I know some people will think it in the back of their head, and this is some of the criticisms we've heard before, but not all psychosocial factors are indicative of mental health disorder. Okay, and that's really important, because this is something that I hear a lot whenever this topic comes to light. I'm not a psychologist, what would I know about psychosocial factors? But I'm not a radiologist either, I'm not a surgeon either. But yes, I'm not denying if an athlete comes to you with an identified mental health disorder that you're concerned about, you should refer them on to the appropriate medical professionals. But many of the psychosocial factors that we covered and will cover in the rest of the presentation aren't indicative of a mental health disorder. They're just normal day-to-day thoughts, emotions, feelings, fears and attitudes that the athlete will have. And we have to recognize that our athletes are not robots. We have to recognize that our athletes don't exist within a bubble. We have to recognize that they have fears and pressures and competitions and emotions like every other patient that we see too. And I think we tend to forget that. So no, you don't have to be a psychologist, but I think you do have to be recognizing the role of these factors in your athlete's outcome and your athlete's return to play after Achilles tendinopathy. And again, this is no surprise. So it might be a small bit of a surprise or new in terms of Achilles tendinopathy, but we know lots of this data from other factors in MSK medicine. So Claire's done some fantastic work in terms of fear of return to play in ACL and the ACL RSI work. But we also know that if we take two of these very, very famous NBA players, and I won't make the excuse that I'm putting patient quotes or player quotes up on the screen today. That's the nature of qualitative research, and I think you have to read some of these quotes to get an idea and understand what the athlete means, because I think they're very, very revealing, and I've highlighted some of these. So the guy in the bottom, which is flipped for some reason, is Derrick Rose. So he played with Chicago Bulls, very, very famous basketballer. And the other guys up here, he was previously with the Pelicans, is a guy called Sean Livingston. So they had very serious and significant knee injuries about 10 years ago and 5 years ago, respectively. And these are just some of the quotes that they have said. So I'm not going to read out every one of them, but I think Sean Livingston's one, which is he's up here and this comes down here for some reason, is quite revealing. So the mental side is the most important side, Livingston says. Your thoughts, the people around you, your self-esteem, how do you feel, all the cliches and all the proverbs. Our human nature allows us to have fear, have doubt to creep in. That just comes with the territory. And that's when he was asked about, how did you find your rehabilitation? How is your confidence now since you came back from your traumatic leg fracture? Okay? So the athletes will tell us these things. We just have to know when to recognize them and how to pick them up and how to deal with them when we're prescribing our exercise interventions as well. So as I said, this story is not a new story when it comes to MSK medicine. Okay? There's lots of research on shoulder pain. So Rachel Chester's work about self-efficacy and rotator cuff tendinopathy. There's stuff on low back pain, obviously, whole dearth of information on that. There's stuff on hamstring, and particularly, as I said, Claire's work on ACL and fear avoidance beliefs and fear of re-injury when it comes to ACL being a predictor of outcome. Unfortunately, we know very little about tendinopathy and Achilles tendinopathy. And as I said, it's not a case that it's going to replace exercise interventions. So this is Jill's progressive model or progressive loading model. Yes, we want to get the athlete from their current capacity up into their optimal capacity, and they have to go through a number of phases to get there. That remains the tenet. That remains the mainstay of our treatment. But those psychological or psychosocial factors act like a dial or a volume button that can turn up or turn down, and can actually delay our time to return to play for some of these athletes as well. And again, we need to be there to match that up with the exercise interventions so we can optimize their return to play. And why Achilles tendinopathy? Why Achilles tendinopathy in particular? So we know that Achilles tendinopathy has a gradual onset, and this can be quite confusing for the athlete. So it's not like a hamstring injury or an acute ankle sprain or an ACL tear where the athlete can remember a sudden mechanism or a sudden incident. And that makes it more confusing for the athlete to pinpoint, because then they start to ruminate and think about other things. Is it coming from my glutes? Is it my training? Is it the runners that I'm wearing? Is it my biomechanics? Because they can't pinpoint one incident, and that can make it very confusing, and it can challenge many preconceived beliefs that they have. Okay, and we'll see some of that in a while. What else? It's persistent and recurrent. As we talk about, they can be very, very resistant to change and very, very resistant to treatment, and they do take a long period of time. And as Jill would admit, I mean, for hamstring or muscle injuries, we're quite comfortable with giving maybe 4 to 6 weeks, and the athlete progresses to return to play. When it comes to tendinopathy, it can be actually double that. But the expectation of the athlete is that, well, it's sore, I can walk on it and I can sort of run on it, so it should be okay in a couple of days after rest. But that's not necessarily the case. And this can feed into the development of these factors as well. And lastly, as I said, it's slow to respond. And that can lead to suboptimal exercise adherence, because the athlete might say, oh, look, I'm sick of this. I've done this treatment now for 2 weeks. I'm not back to play. And that can do other things, and it can drive you towards alternative treatments. And it can drive you towards alternative treatments and treatment gurus as well. So that was setting the scene. So to investigate all of these things, what we did as part of my PhD is we performed an exercise intervention. Okay, So we got runners with Achilles tendinopathy, with persistent Achilles tendinopathy. So they had Achilles tendinopathy for more than 3 months. And what we did is we gave them a 12 to 16 week exercise intervention, a progressive loading program, and measured them pre and post to see what the changes were. But before they entered the exercise intervention, we did some qualitative interviews with the athletes. And what we wanted to do was explore some of their attitudes, their beliefs, their conceptions about why they got Achilles tendinopathy, what is their past experience of dealing with Achilles tendinopathy, what are their fears or what are their expectations for the treatment and expectations going into the future in terms of prognosis. And I must say, for me, it was hugely revealing, and for me, it's definitely changed my clinical practice since we performed some of these interviews. And what we've done recently is that we've replicated this in an Australian population, because you may think that, well, all those Irish people are a bit daft anyway, so maybe it was just them, maybe they're the ones with the issues. But we've replicated it in an Australian population. That data is due to come out soon as well, in athletic populations, running populations, the type of populations that we will see with Achilles tendinopathy. So I'm not going to go through every theme that we identified from these studies, but some of the themes that stood out for me and will have an implication for you as the medical practitioner dealing with these athletes with Achilles tendinopathy are some of these. So one of the ones was the emotional impact, or just the sheer impact of Achilles tendinopathy on a runner's life and runner's athletic identity. So some of these are important. I think just take a moment or two to read some of them. Not all of them, but just some of them, okay? Because I think this is important data. This is as important as putting up a graph and looking at your XY plots. I think you need to read these to understand the impact Achilles tendinopathy has on some of our athletes. So some of the things that they would say is that at the moment it's not too bad. I guess when it's at its worst, it does. It's sense that gets you down because it's limiting your training and you want to get going with stuff. Particularly when it's come round again and you feel like you've treated it, it's come back. You're like, no. You just start throwing different things in it to see what works. Yeah, you end up thinking about it a lot. So like there is 5 or 6 things within that paragraph alone that I think are really important. In terms of, yes, getting them down, limiting their training, suboptimal exercise interventions, alternative treatments. All of that within one paragraph are some of the roads that your athlete can come down if we don't identify these factors early enough in terms of emotional impact. And again, that's not all. So some of the other ones are fear avoidance beliefs. And this is quite a big one in terms of fear and worry about rupture in people with Achilles tendinopathy. And as we might know, that up to 60% of people with an Achilles tendon rupture never had any symptoms or pain. But again, it's very much a worry from athletes about, well, if I load my, how can you ask me to load my Achilles with a Smith machine 2.5 times my body weight? How can you expect me to do that? I have a fear about rupturing my Achilles tendon or loading my Achilles tendon. How do you mean it's okay for me to run? I have this 6-month history of Achilles tendinopathy. If I run, I might actually rupture or make it worse. Okay? And it's a very hard explanation to get across to the patient to say, look, yes, I know your tendon is irritable at the moment. We might have to scale back your running, but running is not necessarily a bad thing. If we can match that up with your rehabilitation to make you stronger, to make you more load tolerant, we can continue to let you to run, and we can slowly increase your running. Okay? So it's not that your tendon is inherently damaged. It might be just the case it's just a bit irritable at the moment, and we need to increase your load management or decrease that irritability of the tendon as well. Okay, and that's really important about that fear avoidance beliefs. And just very lastly, before we finish on it, it's just that confusion. Okay, what we inherently think, the assumption that the athlete knows what you're talking about when it comes to confusion and patient education, and the potential importance of patient education when it comes to Achilles tendinopathy as well. So some of the things is that don't do anything, I don't know enough. That was crazy. I think this was a really, really nice one. This is my favorite quote from the 2 studies that we've done. So I was asking this guy about, well, has he tried exercise for Achilles tendinopathy? And he says, yeah, look, I did that exercise intervention, you know, when you go up and down your toes. I did that every day. But this was his quote about it. There was a therapy that was recommended to me, maybe to start of the year. It was called heel drops or painful heel drops. Was it 10 minutes a night, every night for 12 weeks? But in my head, that was crazy. So we might give the exercise sheet or the exercise prescription to the patient, but how the actual patient interprets the exercise that you've prescribed to them might be totally different to what you assume. And that's really important as well. So I think from those patient quotes, it's really important that we identify and recognize that psychological or psychosocial factors are relevant in Achilles tendinopathy, and it can affect their outcome, and in particular can affect their treatment outcomes when we prescribe exercise for these athletes. And I think it's important that we ask ourselves, well, how often do I ask my athletes about some of the factors we just covered? How often do I take time to explain their pain to them? How often do I discuss the expected recovery time, that, well, this isn't going to be a 4-week thing or a 3-week thing, this might be a 12-week progressive loading intervention. And the question is, well, why or why not? Are these components unimportant or not important in tendinopathy? And I think we've just showed that these might be, in fact, very, very important when it comes to Achilles tendinopathy. So, finally, just nearly closing up, is that, well, okay, you say these are important, you kind of shown that they may be there. Well, how do I identify these factors in my athlete if I'm working with this athletic squad? Well, is it a case of finding a needle in a haystack, or is there a progressive way that I can identify these things in a systemic manner? So, yes, there are very much formal outcome measures out there that can be used to identify psychosocial or psychological factors in athletic populations. So we have such things as the Tampa scale of kinesiophobia, which has been used in low back pain and also in ACL injuries. We've pain self-efficacy questionnaire, and we've also athletic identity measurement scale. And all these scales have been validated in sporting and athletic populations in terms of rehabilitation outcomes and in terms of screening for psychological and psychosocial factors. But we know very little about them when it comes to tendinopathy and Achilles tendinopathy. So they're formal measures, but you may not need formal measures, and I think that's a foolish way of looking at it, because what we want to do is to try and understand the athlete a bit better, and maybe sometimes complexity is simplicity, because we just need to just scale it back a small bit. Stop making it complex, because maybe being over complex, particularly with the athlete, led us down this road in the first place. When it comes to imaging, when it comes to explanation of their problems, maybe we've done too much of that, we need to scale it back. So I'm sure that this man will be very, very glad that I put up a picture from 20 years ago, and I was very tempted to put up another picture of him on a triathlon a couple of weekends ago, but he's going to hold it for his presentation in a while. But sometimes one of the simplest things you can do is that at the end of your treatment, just ask the patient, well, what will you tell your partner, your wife, or your sister, or your brother when you go home about what we covered in today's session? Can you repeat that to me, or just tell me what you're going to explain to them about Achilles tendinopathy? And you will be utterly surprised about what they'll actually tell you. What the patient actually has taken away from your interaction with them might be hugely different from their interaction and from your interaction. And it's about trying to find that middle ground about your understanding and your patient and the patient's understanding. And again, that will hopefully then optimize the outcomes when it comes to exercise prescription as well. So some of the things that we can try and do is that, well, can we just choose our words carefully? So when it comes to imaging, can we not tell the patient that that's a terrible looking tendon? That's a tendon of a 70-year-old or a tendon of an 80-year-old. You've got a massive tear in your Achilles tendon. I'm not quite sure you'll be able to make the track and field next year with a tendon like that. I'm not quite happy you should be running with that tendon. Can we temper that a small bit? Can we just explain to them, well, at the moment you have a very irritable tendon. Can we use positive reinforcement, reduce fear and catastrophizing, emphasize that pain isn't damage, emphasize to them that, well, what we see in imaging is only one static picture, that we can improve outcomes, and we know that patients get better without actually changing their imaging at all. And there are some of the challenges that we have to do as clinicians when we're dealing with patients with Achilles tendinopathy too. So we can just shift our words. We can be a bit more positive and less negative, be a bit more less fear avoidant, and be a bit more positive when it comes to enhancing self-efficacy in our patients as well. So, I don't know, Darren Paul here. I found this classic photo of Darren Paul, but these are just some of the techniques that we can do. So they can be informal or they can be formal, whatever we want to do. But this is one of the methods that I usually follow. And in a takeaway after an athlete has Achilles tendinopathy and I see them, or I see an athlete with ACL, these are some of the things that I'll probably ask myself. Well, have I provided the athlete with enough time to practice the exercise program? Or do I do the usual thing where, okay, well, we did spend 40 minutes doing assessment and objective measures. Here's your exercise sheet. Away you go. I'll see you in 3 weeks' time. And the athlete has never practiced exercise intervention with you. Information. Can we clarify or identify any negative beliefs? Can we address some of those factors before the athlete leaves the clinic, so they have a clear picture about what is going on and a clear picture about what they need to do? Explain. So have we provided adequate time to express or discuss the extent of the injury? As I said, Achilles tendinopathy can be really, really confusing for athletes because there's no mechanism of injury, and this can cause massive confusion. So have we provided adequate time for the athlete as well and to discuss these factors? So in terms of criteria, have we given them a self-management process? So how can they progress the exercises? Do they progress the exercises with load? Do they progress it with time? Do they go into more rehabilitation exercises or plyometric exercises? Is the coach aware of some of these things as well? Is the coach on board with you? Is he aware of the exercise intervention that you've prescribed to the athlete? That's really important as well. And just finally, simplicity. And again, that goes back to that complexity versus simplicity factor we talked about. Can we avoid jargon and complicated language which is likely to be misinterpreted by the athletes? Can we scale it back and make it more simplistic for the athlete to understand? And can we develop that rapport a small bit better with the athlete? So instead of thinking this of, well, oh, here he goes again talking about psychosocial factors, can we stop thinking in a dichotomized manner of psychosocial factors and physical factors in terms of integrating into one model of that biopsychosocial response? Not every athlete will have dominant psychosocial factors, but there will be a subset of athletes who will have psychosocial factors that need to be addressed that will affect their treatment outcomes and their rehabilitation outcomes. And it's really, really important that we identify that and address that to optimize the outcomes for athletes as well. And just very, very finally, we're quite comfortable with functional demands about, well, my athlete's profile is here, they need to just be able to walk, or my athlete's profile is down the very, very other end where they have a high plyometric loading demand, and I will design my exercise intervention accordingly to get him to this point here, or I might only need him to get it to this point here in terms of walking. And it can be any way along that continuum. But it's the very same too when it comes to psychosocial factors. That is what is going on there. Oh, my favourite photo is gone. That was a monkey brushing his hair. I quite like that one. He was just chilled out sitting in the bathroom. It's absolutely epic. So there's a continuum as well of psychosocial factors, and it's the very same as exercise description. Not every athlete will present with dominant psychosocial factors, but we need to identify the ones that do, and we need to intervene appropriately when they do display signs of fear avoidance beliefs, catastrophizing, poor self-efficacy, poor coping strategies, inappropriate expectations when it comes to treatment too. Because if we want to get to this point here, we need to be able to deal with this point here as well. Okay? And it's a shift in mindset when it comes to us as athletes, or for the athletes, and it's a shift in mindset most importantly for us as medical care practitioners as well. So where does your athlete lie, and what can you do to help them achieve their desired function by integrating some of these factors? Thank you very much for your attention.